Okay, go ahead, Risha, with the
Second,
next part of the
second question. Yes.
question.
Uh, discuss any three agents used for ICU sedation. Stressful experiences during ICU stay can have prolonged neuropsychiatric effects. The stressors can be unrelieved pain, which happens during suction or turning the patient's position in the bed, inadequate sedation, inability to communicate in case of intubated patients, difficulty in sleeping, hallucinations, nightmares, etc. So, there comes the role of the sedation. Drugs drugs used are benzodiazepines, which includes midazolam, which is commonly used, then propofol, opioids, and dexmedetomidine. Here I will discuss about the midazolam, dexmedetomidine, and propofol. Midazolam, which is highly lipid-soluble benzodiazepine, which is short-acting, and it is also a rapidly acting drug. Mechanism of action is usually selective on GABA A receptors and usually found in the CNS synapses and opens the chloride channels. Advantages of using midazolam is it can create antidepressant amnesia. It is an anticonvulsant and also a drug of choice for the withdrawal symptoms. Disadvantages, since it is highly lipid soluble, it is highly lipid soluble when compared to other benzodiazepine groups. Drug accumulation is the most common problem. Then delirium. Uh, then, it also prolongs the awakening time when we switch, when we stop the sedation. These are some disadvantages. Coming to the pharmacodynamics of the drugs,
Please check your audio, ma.
in
You're
CNS,
saying, please
yes,
check your audio whether it is all right. There's vibration. If others are keeping their audio on, please mute it so that it will be clear. Go ahead.
yes, sir. In CNS, it's actually a good anticonvulsant. Can create a hypnosis, sedation, and anterograde amnesia, and also reduce the cerebral metabolic blood flow and oxygen demand. In CVS, they can reduce the MAP around 10 to 15%, and they can increase the heart rate around 18%. In a respiratory system, they can increase the risk of upper airway obstruction, and they can suppress the hypoxic ventilatory responses. And there is also synergistic depressive action when combined with the opioids, when combining with the morphine. Then also there is a reduced post-op nausea vomiting incidence. Coming to the doses, when coming to a loading dose, we give 0.02 to 0.04 milligram per kg. Then the onset time will be 15 to 20 minutes. Duration of the drug will be around 2 to 6 hours. After loading dose, we can give a maintenance of 0.01 to 0.1 milligram per kg per hour, which should be around less than or equal to 10 milligram per hour can be given. Then the side effect is we can expect hypotension, bradycardia, respiratory depression, and delirium in case of critically ill patients. So solutions, drug interruptions can be done. Then we can also titrate to sedation, RAS scale and RAS scale, which is Richmond agitation, sedation scale, and sedation agitation scale. Then recently, we are slowly coming out of the use of benzodiazepines for the ICU sedation. In coming to dexmedetomidine, which is an alpha-2 agonist, and it is a very good sedative, hypnotic, analgesic, anxiolytic, and sympatholytic. They do not depress the ventilation. Mechanism of action is sedation and anxiolytic form. They usually act on the pontine locus coeruleus in brainstem. Firing of the inhibitory neurons be there. Analgesic action via the dorsal horn, alpha-2 receptors, and they can reduce the release of substance P. And they also have a cooperative sedation where patient can be aroused from the sedation without discontinuing the infusion. Coming to pharmacokinetics, loading dose can be 1 microgram per kg over 10 minutes can be given, and the onset time will be 5 to 10 minutes. Maintenance can be given a IV of 0.2 to 0.7 microgram per kg per hour, and the arousal time is usually around 6 to 10 minutes. Uh, it's usually eliminated by the kidneys. And pharmacodynamics in the CNS, there is an arousable sedation with hypnosis is usually present. They can reduce the cerebral blood flow and cerebral metabolic oxygen rate. They can reduce the ICP and suppress the stress responses to the surgery also. Coming to cardiovascular system, they can reduce the SVR and heart rate. Then they can also reduce the risk of perioperative MI. Then there will be hypotension and bradycardia, which is a common side effect. In respiratory system, they can maintain a good ventilatory response to CO2, and no changes in PaO2, pH, and ventilatory responses can be seen, which makes them ideal agent for ICU sedation. Side effects are dry mouth, nausea, bradycardia, hypotension, which is usually seen. There are some areas which is contraindicated to use dexmedetomidine where the patient is in heart failure, or the patient is having a second degree, third degree AV blocks, or there is an uncontrolled hypotension and patient is hemodynamically unstable. Coming to my third agent of ICU sedation, which is propofol. This is a sedative, hypnotic, and also lipid soluble. Mechanism of action is it's a selective modulator of GABA A receptors, usually act to inhibit the neurotransmitters and promote the glycine action of the glycine receptors. It also has an NMDA antagonist action. Here they can be given a loading dose of 5 microgram per kg per minute, and the onset of action will be 1 to 2 minutes. Maintenance IV doses can be titrated between 5 to 50 microgram per kg per minute. The arousal time after switching off the drug can be 10 to 15 minutes, and it causes respiratory depression. One drawback is propofol is not an analgesic, so we need to add the analgesic doses to keep the patient stable. Then metabolism is 5 liver. Another one thing is 1 kilocalories per ml of propofol doses will be added. So it should be titrated to the caloric chart while calculating the diet. Then they can reduce the cerebral metabolic oxygen rate and blood flow, and also can reduce the ICP. And it is also got an action of anti-epileptic. In CVS, they can reduce the blood pressure from 25 to 40%, and also they decrease the myocardial contraction and the cardiac output. In respiratory system, they can depress the respiratory center and produces apnea and loss of airway reflexes, which is needed in the ventilated intubated patients, and also act as a very good bronchodilator. Side effects, as I said, it is not an analgesic, so analgesic doses should be given. There will be a pain on injection site. Bradycardia, hypotension will be there due to the vasodilatation. And if more than 24 hours continuous infusion is there, we can anticipate propofol infusions. Then hyperlipidemia, which can sometimes trigger pancreatitis when prolonged infusion. In rare cases, there can be a green urine occasionally due to tolerance.
Okay, good. So you can choose the drugs that you want to describe. If they give an option like this, describe any 3 drugs that are used in ICU sedation. So it becomes easy for you. And we commonly use propofol, midazolam. Nowadays we prefer to use dexam also because of the advantages that it uses. So if you want to save time writing this question, what I would suggest is you can put a tabular column and then mention about the physical properties of the drug in first column, second pharmacokinetics, then the pharmacodynamics, then the unwanted side effects, then the dose and the response. All like that, you can make a tabular column. So I will show one such column that has been there in the